All right, perfect. All right, take it away, Nemesis.
Hi, everyone. So today I will be talking about pectus excavatum, more specifically about the repair of pectus excavatum. So starting off, pectus excavatum or funnel chest, it's a deformity of the chest wall and is characterized by a sternal depression. It's also related to congenital deformity. We can see on the next slide, this is a case of a severe sternal depression. So pectus excavatum accounts for the 9% of anterior chest wall disorders. The incidence is 1 in every 400 to 1,000 live births, and it's 3 to 5 times more prevalent in males than females. Can anybody guess why it's not seen as much in females? It's really easy. It's if you picture a physical exam. So females, we have breasts. Yes. Yeah. So as for the etiology, so PE or pectus excavatum is associated with connective tissue such as Marfan, Ehlers-Danlos, and is also related to neuromuscular disease such as spinal muscular atrophy, and it's also related to genetic conditions such as Noonan syndrome, Turner, and neurofibromatosis type 1, and MEN type 2. The increase of the PE and connective tissue disorders suggests that there is a possibility that it is caused by abnormal cartilage development. There's hundreds of hypotheses on this topic, and it's not like something confirmed. As for the clinical significance, it depends on 3 issues. So the severity of the chest wall defect, the cardiopulmonary morbidity, and the psychosocial impact on the patient. Some of the clinical features and symptoms you can see in patients, it's exercise intolerance. This is mostly like the `1 symptom you can see on adolescents. Like when compared to their peers, they don't have the same tolerance to exercise. They can have chest pain, they can have tachycardia or orthostatic hypotension. They also show with shortness of breath, and the last one will be cosmetic concerns. Patients with severe PE can have tachycardia, which is due to a reduced stroke volume depending on the distortion and the displacement of the heart. So when to refer the patient for surgery? Obviously, symptomatic patients. Patients with a Haller index greater than 3.2, which we will be talking later on. PCI greater than 28%. Patients with cardiac compression or displacement. They can show with mitral valve prolapse or other type of murmurs. When pulmonary function testing shows restrictive respiratory distress, failed previous repair of the pectus excavatum, and pectus excavatum deformity with worsening or of psychologic symptoms. As for the age, it's a debatable topic. It usually is around 11 to 14 years of age. The repair can be around 12 years old, because there is a risk of recurrence if we operate earlier on the patient. I found 2 articles. One is called, no, I don't have that. One is called the 21 years of experience with minimally invasive repair of pectus excavatum by the NUS procedure. And it discussed the learning curve and changes of the age of initial NUS bar placement. And then there's another one called increasing age at the time of pectus excavatum repair in children. And they try to study and show which is the adequate age for the to take the patient for the repair. It increased from 11 to 14 years of age. As for the workup, the initial workup will be a CT of the chest, an echocardiogram, pulmonary function test, and allergy test. Allergy test is related to the use of the bar in the nose procedure. So if you can see in the picture B and picture C, picture B, you can see that the yellow arrow is pointing at the position of the sternum. And in picture C, you can see the depressed sternum and how the right atrium is being compressed by it. When measuring the Haller index, which I mentioned earlier, or the PEC2 severity index, it's the same thing. For the patient to go to surgery, it has to be more than 3.2. The normal will be between 2.5 and 2.7. And as the Haller index increases, the cardiac and pulmonary function decreases. And for the PEC2 correction index, as it increases, the exercise capacity decreases.
Nemesis, sorry, I have a question. Why do they do an allergy test as part of the workup?
For the bars using the noose procedure, they can be for titanium or nickel or nickel.
Okay, my bad. Okay, makes sense.
Yeah. Okay. So here I show you a picture of how you measure the defect. So for the correction index, point A is measuring the distance between the posterior sternum to the anterior spine, and point B will measure the distance between the anterior spine and the anterior portion of the chest. You will subtract both and then divide it by the B point times 100. For the Haller index, it's just A divided by B, which A will be the transverse diameter of the chest, and B is the anterior posterior distance from the spine to the sternum at the deepest portion of the defect. There are non-operative treatment, which is the sternum suction or the vacuum bell. I didn't put a picture. You can have a prosthetic insert or just physical therapy. So the history of surgery. So in 1920, Sauerbruch, he resected both deformed ribs and the cartilage, but this after we create a flail chest. In 1930, Brown removed the abnormal cartilage and performed a sternal osteotomy and released the sternum from the inward pool of the diaphragm. In 1940, they worked on the central tendon of the diaphragm and substernal ligament were released. There is not much information about this one, so it didn't work. On 1940, Ravitch made the open procedure, which was currently known. And this one, he resected the supraechondral cartilage and did a posterior sternal osteotomy and a temporary internal fixation to support the sternum. After Ravitch, it came the noose procedure by Dr. Donald Noose. That was in 1998. And later on, in 2016, it came the PEC2 sub or taulinoplasty, which we are going to talk about both of them. Here is a picture, so you can, if you're a visual learner, you can get an idea of how the procedure works. We have the Ravitch, we have the noose with the bars, and then taulinoplasty, which is more like a plate. So the key points for the noose procedure, you're going to have a sternal elevation, then you will have a mediastinal dissection, the stabilizers, and then you elevate the sternum and you put the two bars, which later you're going to rotate them. Here is a picture of it. And as for the taulinoplasty, you create an incision in the chest, then you insert the sternal plate. You put the implant in place on top of the sternum. Then you're going to lift the sternum to the desired position. You'll place the screws on the implant, and then the implant will be fixed to the sternal plate. Each turn you do when elevating the sternum, the turn is going to be counterclockwise, and the power of each turn equals to 2 millimeters of lifting. So each turn is you're lifting 2 millimeters. And here is another picture. This is the plates you're gonna insert. And now to talk about the paper. So first off, this was a pilot study, meaning it's just a preliminary and it's a small scale study. It was single center based in Barcelona, Spain. It was unblind, so both the researchers and participants know which treatments are being done. It was non-random, and it is a prospective study, so it's moving forward in time from the point of enrollment to observe the outcomes. As for the data, so the study was done from 2012 to 2017 with 49 adolescents, 23 underwent taulinoplasty, and 26 underwent MIRPA or the Nuss procedure. The median age for both were 14. So the operation time for taulinoplasty was 60.4 minutes, and for the Nuss, it was 70.7. As for the hospital stay, the patients who underwent taulinoplasty had an average stay of 5 days, and the Nuss patient had an average of 8 days. For postoperative pain, patients require fewer days of analgesia who underwent taulinoplasty, and they use dural, they use IV, and they use oral analgesics. As for complications, there were no difference between Nuss and taulinoplasty. Most of the common complications for Nuss are the bar displacements and infection because of the bar. So the safety endpoints and analysis for the study show that there were no difference between both of them, and the rates of infections for infections, pneumothorax, DHEADS, and seroma, and pulmonary edema were also similar for both procedures. The efficacy endpoint of taulinoplasty, which is the Haller index, was measured 5 months after the procedure, and it did present a significant reduction of the Haller index. So in summary, taulinoplasty has low rates of major and minor complications, as do the Nuss procedure, and there were no significant complications compared to the other technique. As for the limitations of the study, one was that it was a single center unblinded design, so there might be some bias around it. Nevertheless, the promising results encourage that it should be a continual analysis to validate the findings in older cohorts and with different surgical teams. Second, the patients were not in a highly asymmetrical or lung or a severe depression. So the population, this was based on this less severe population. So it should be investigated in those patients with severe chest depression or a higher Haller index. And these are more of the articles that you can read about, which show there's still modifications made to the NUS procedure. There is one of when is the adequate time to remove the bars. Right now, it stays from 3 to 5 years. The bar stayed in place. Same for the talinoplasty, the plate is 3 to 5 years before the removal. For the NUS procedure, there was a new modification, which you can read on the paper that is called Crane Power Pectus Excavatum Repair. And there is still the non-thoracoscopic versus the thoracoscopic repair in the NUS procedure. There's a video, there's still time, or if we can go to a question, but it's just showing you how the procedure is done.
I can try the videos. I think we have time. See if they work. You guys can see it?
Yes.
Do we know if there's sound?
No.
Okay.
So this is the plate. Then there will be a ball joint and screw, which is how you will start elevating the sternum.
Yeah.
That's the traction system. You can stop it, but yeah, it's basically it.
I didn't know if you want me to play this one too. Yeah.
If you want to, if not, that's fine. NUS is more, I think it's not that visual, it's just inserting the 2 bars. But the other one, I just want to show it.
Okay.
And that's it.
Great. Thank you, Nemesis. Does anybody have questions for the doctor? Or do you have any comments?
I did have a question. First of all, Nemesis, that was a great presentation. Good job. I was wondering if they leave the hardware in after they're like finished growing, or if that's something that they continue to have for the rest of their lives.
No, they remove it after 3 to 5 years.
3 to 5 years. Okay, thank you.
I have a couple of questions, if that's okay. Sorry, Mona. The 2 measurements that were there, is it for one's for the NUS procedure and one's for the talinoplasty?
This one?
Yes.
Yes, because this is how the severity index, and you need this to go into surgery. So they're used both in NUS and this is part of the workup.
Okay, so they're both used for each procedure then?
Yes.
Okay. Okay, that's what I
Yes.
wanted to clarify.
Yes, they
And
compare
then
the outcomes of the Haller index pre-procedure and post-procedure. And I don't know if you saw in detail the numbers of the tables. Usually the patients that underwent NUS procedure had a higher Haller index and the patients that underwent
Oh,
taulinoplasty. I think that's
okay.
interesting in terms if you measure the other modifiers that they had. They were talking about postoperative pain. If you have a higher Haller index, you have a greater deformity that's being repaired. So I think that can contribute more to the pain. No, you can keep asking questions. I have a couple of comments afterwards.
Okay. I just had I guess it's more of a comment because I was just thinking like they bolt into the sternum for the telenoplasty and it just shows them they just raise it up all at once. Have they looked at, I guess, a difference in doing it all at once versus like a little bit at a time at different times for more severe deformities? My mind I know it's completely different, it's like apples and oranges, but went to like braces where they adjust, it at different times.
So you mean like when the patient going to the OR, if it's lifted just only once, or if they
Yeah,
can, or
exactly.
afterwards? Yeah, because they started to lift the sternum until the desired position, but it's like they don't just start lifting it up all at once. They go step by step, but it's in the same procedure.
Okay.
Yes.
Okay.
Yeah.
Thank you so much, Nemesis.
So I had a question about post-procedure. Do these patients require like physical therapy afterwards?
I don't have the answer for that, but mainly yes.
Usually,
Honest-
they're kids. They're 12 years, 14 years old. And the third day, they're usually just already walking around. We do a lot of noose procedures. We don't do many taulinoplasties. And these patients, we recommend that they start swimming, they start running, they start their daily activities to help them grow. So yeah, usually they don't really need physical therapy, standard protocol, but they do need an exercise regime that they need to be strict with that. It helps them a lot and helps them grow into the defect.
What
Great
kind of,
presentation.
oh, sorry, I had like a follow-up question. What kind of like physical therapy or like exercises would they be given? Or like, is there anything that they wouldn't be allowed to do with the equipment in?
They can do anything. We mostly recommend swimming. That really helps expand the chest wall more than anything. Swimming and running, which help with pulmonary function. So those are mainly our two main recommendations for these patients.
Okay, thank you.
I just had one question. So great presentation, first of all. I really enjoyed it. It was very enlightening. So starting off Ravitch procedure, then NUS, then now the taulinoplasty. So I guess my question is, what is a better indication for doing like a Ravitch versus a NUS versus a taulinoplasty? And are there any papers that you may have come across as to, like, for example, the long-term complications of taulinoplasty? Like, because NUS and Ravitch have been studied over the years, and we know, like, for example, with NUS, you have a higher risk for bar displacement, especially if you're doing the procedure in adults, versus in Ravitch, because it's such an invasive procedure, you have a higher risk of wound-related stuff, so like infections and stuff like that. So I was just wondering if there are any studies that talk about the like long-term complications of taulinoplasty over the others.
So for taulinoplasty, this is really recent, and the work has been on Italy and Spain right now. There's not much here in the US. So that's why the paper is just like a prospective study so surgeons can work more on it. And that is more, I believe it's more like it depends on the surgeon doing the procedure. Like noose will always be like the standard or the go-to procedure, because if it is more known. When comparing them on this paper, you can see that there's really not much that significant difference between them. And like you mentioned already, the most common complication for the noose is just the displacement of the bar, and eventually the bars come off. So yeah, but it's still a work in progress, I believe, and I believe if doctors continue to study, talonoplasty can be a good option. I don't know if Dr. Monserrate has anything to add.
What do you guys think about this paper in terms of comparing the NOS versus the talonoplasty? Just in terms, what do you guys believe is a better option and why?
I mean, I think colonoplasty potentially could be a better option because, I mean, shorter operative time compared to, for example, the NUS. It can be done for both like adults and children, so could potentially be superior to other procedures, but I'm not sure. I think that's what I think.
And also it's less invasive, right? It's not intrathoracic. So I see just like less incidents for injury to like surrounding structures and things like that. So I could see it being superior in the future once physicians, surgeons are more comfortable with the procedure.
I like talonoplasty as well. Just looking at the mechanics, it looks more secure, whereas the NUS one, you could tell it could move easier. Talonoplasty, it's fixed, it's one spot. And going back to Melissa's question, I feel like if they need to go back, they can fix it and like pull it up more, or pull it down more or something. To me, this is that, yeah, it looks like braces where you like need to fix it here and there. I think it's easier fix it. They need to fix it than the NUS one. The NUS one doesn't seem, to me, it doesn't seem secure enough to play around with.
The bar in the NUS procedure is usually very secure. It's tied on the lateral edges of the thorax. Its place is bar displacement is really not it's one of the most feared complications of the procedure, but it's not very common. But it can happen. In terms of intrathoracic structure injury, this study tried to see if there was any difference in terms of the two. There was really no difference in terms of whether you're going to damage surrounding structures. I know there's a sense of fear when you're entering the thorax. You can damage the heart, the aorta, or a lung, or the mammary artery, which is right there. But it really, you do it with a thoracoscope. You're watching exactly where you're placing the bar. So if everything's done correctly, the risk of damaging anything is very minimal. As you can see, there was no damaging any of these patients. In terms of operative time, it's another point I wanted to touch with this article. If a center is more focused performing talonoplasties, I think their operative time is gonna be less than if they're more experienced performing NUS procedures. For example, the surgeon at our institution, he does a lot of NUS procedures, and I can say he did it in 40 minutes. It's very fast. So in terms of operating time, that's very surgeon dependent. And since being a single center study, that's something that really needs to be extrapolated to other institutions. Yeah.
So I see that it said in the paper too, so comparing the NUS versus the talonoplasty, ICU stay and length of hospital stay. So is that something at your institution? I know you don't do a lot of talonoplasties, but that this paper talked about, if you guys noticed that at your institution.
Our patients usually stay 3 to 4 days, so it's not much different from what they're staying here, so it's usually the same. They did have an epidural catheter. It was removed on the 2nd day usually, and on the 3rd day they start walking. If they're fine, they leave on the 4th day. If they stay one more day, then they stay 5 days. So it's more or less the same post-operative time. They do spend 1 or 2 nights in the intensive care unit just in case. So yeah, we do more or less the same. As we don't really do talonoplasties yet, I think it is a great option in the future. I think it still has a lot to develop from. I do think it's much easier to remove that plate when you're going to remove it in 3 years than removing an intrathoracic bar. But yeah, this was really developed in 2016, so they're just starting. We still have to see the long-term results with this. Non-operative management, Nemesis mentioned the the vacuum. I don't know if you can visualize it, but it's a vacuum bell. It's like a bell that goes in the center of the chest. The patients have to place the bell for 4 hours every day for 2 years to see some sort of improvement. So it's something, the sternal suction, I don't know if that's the way to go. It sounds like a long, long time with something 4 hours every day to see if you can get some sort of improvement. So yeah, I think as time goes on, the Talinoplasty is gonna be a good option. For now, I still think the NUS is the gold standard.
I have another question. With that suction, have you seen anyone that's had to have that, and is that painful? Like, I don't know,
Yes,
that's
they don't tolerate it that well. They say they can do 2 hours, 3 hours, and they can't continue to do it. And if they're children, they're in school usually all day. So that means getting back from school, getting at home and putting the suction cup on for 4 hours every day. I don't think it's practical.
right.
And something that's not very talked about often in terms of cosmetic, a patient with severe pectus excavatum, even though he doesn't have any pulmonary function test altered or cardiac function is completely normal, the term of cosmetic surgery for that, I think is something that should be talked about more, because they're the ones that live with that defect for the rest of their life. And if it's not corrected in time, it's usually not going to be corrected and they get operated later on. So that's something that's not talked about much, but I think it should be included in many of these discussions going on.
I did have a question. Do we have any cases, I don't know if this has been asked, but do we have any cases of the condition reoccurring even after the surgeries have been done?
Can you repeat? Sorry.
So do we have any cases that we know of, like of the conditions reoccurring even after the surgeries have been done?
So conditions the patients develop or the condition of the patient?
Like this, like the pectus excavatum, like does it ever return, like even after surgeries have been done, or is it usually just 100% like
Yeah,
defective?
it can recur. I don't know the exact number, but it does recur sometimes. It's not usual, but yeah, it can recur. Nemesis, great presentation. I think you covered all the topics. You really supplemented with other papers. I really liked it, and the videos were. I like the videos also. Oh, also, we don't usually place 2 bars unless needed. We only place 1.
Nemesis, are you here?
Yeah.
Oh, okay. I didn't see you.
Thank you.
Yes, thanks again, Nemesis, and
Thank you.
Dr. Monserrate. Does anybody have any final comments, questions, or anything like that?
I was actually just looking up rates of recurrence for this. Approximately, they're saying it's less than 10%. On average, it's 2 to 7% in centers where this is done. So pretty rare.
Yeah.
Recurrence.
Thank you.
Great, thank you. Well, if that's everything, then we can move on to our housekeeping things for the month. And once again, thank you so much for the presentation, Nemesis, and Dr. Monserrate for being here on a Saturday.
Thank you, Dr. Monserrate.